Okay, let's dive in. We're looking at something pretty foundational today, but maybe with a bit of a twist. Clinical scoring systems in primary care.
Right. These are those tools, designed to take different bits of patient info, symptoms, history, maybe exam findings, and kind of boil them down into a score.
Yeah, a single number.
Exactly.
Yeah.
And the idea is that score helps predict an outcome or maybe guide a clinical decision.
And our source material for this deep dive, it feels spot on for this. It's a 2025 BJGP review teaching summary written specifically for family physicians, right?
Yeah, exactly. It really tries to cut through the academic side and focus on what a clinician, sitting with a patient actually needs to think about with these tools.
Perfect. So our mission here is to unpack what these scoring systems are, what they're supposed to do, but really dig into what this review says about their actual use in practice and highlight the key benefits and maybe more crucially, the significant limitations the source points out.
One number from this review just jumps out right away. They mentioned over 250,000 scoring tools developed across medicine.
Wow. 250,000?
250,000.
That's staggering. You'd think with that many, these things would be everywhere, indispensable.
And that's exactly the sort of key tension this review flags immediately.
Yeah.
Despite this huge number of tools, their actual practical use in day-to-day clinical practice often remains pretty limited. It really makes you ask, why? Why aren't they more central if there are so many?
Okay, and that why probably starts with context, doesn't it? Because a core message, maybe the core message from this review, is that these scores should support clinical judgment.
Right.
They shouldn't replace it.
Absolutely crucial. They're algorithms, data points, but they don't see the whole picture. The clinician's experience, their feel for the individual patient, their specific situation, it's still paramount.
And the review also notes that surprisingly few out of that 250,000 plus are specifically tailored or even really validated for UK primary care specifically.
Which really matters, doesn't it? Because the patients are different, how illnesses present, the time pressures. It's a whole different ballgame than, say, a hospital ward.
Totally different.
The review does mention some familiar examples, though, often for things like sore throats, Centor, McIsaac, FeverPAIN scores, things people might have encountered.
Okay, so let's stick with that sore throat example. Looking at what the source says about the actual evidence, you'd hope using a score leads to, clearer decisions, maybe fewer unnecessary antibiotics. What does the review say the evidence shows?
Well, it's pretty blunt, actually. The review describes the evidence on using these scores for sore throats as mixed.
Mixed, okay. So not a clear win. Does that mean sometimes they help, sometimes not? Or the studies are just inconclusive?
It suggests the impact isn't really consistent. The goal might be to target antibiotics better, but the actual effect on cutting prescriptions or even helping symptoms faster across different studies. This is not a slam dunk. This is not always making a difference.
And they mention rapid tests, too, sometimes used alongside these scores.
Yeah, and the review points out that adding those often just adds complexity. It complicates the consultation flow.
More steps.
More steps, exactly. Without clear proof that it actually improves patient outcomes in the end.
Which kind of makes sense when the source reminds us about the basic clinical reality. Most sore throats are viral, and serious complications are actually quite rare. So overcomplicating the assessment for something usually self-limiting maybe isn't the most efficient use of time.
Yeah, practicality is a huge factor.
And that practicality, that brings us right to usability in the clinic. What do clinicians, in the middle of a busy surgery actually find helpful?
Well, it has to be quick.
Yeah.
Simple. Practical.
Right.
Anything that adds significant time or faff is just, it's not going to get used much.
It'll sit on the shelf.
Yeah, exactly. They mentioned the FeverPAIN app specifically as something that got some traction.
The app format.
Yeah, precisely because being digital made it easier to use right there, right then, compared to maybe filling out a paper form or trying to remember all the criteria off the top of your head.
Makes sense.
Yeah.
But even for seemingly simple tools, the source highlights a key constraint. If a score needs any extra tests or steps beyond the usual chat and examination, steps that take extra time, it gets really tough to fit into that standard, 10-minute GP appointment?
Oh, absolutely. That time pressure is just a massive filter for what actually gets adopted in practice. Huge barrier.
And beyond just being easy to use day to day, there's another big hurdle the review mentions, generalisability. Explain that a bit.
Well, a lot of these scores were developed and tested in very specific groups of people, maybe in research settings, often less diverse than the population walking into a typical GP clinic.
Right. So a score might work great for, say, young, otherwise healthy adults in a trial.
Exactly.
But maybe not so reliably for an older person with 3 other long-term conditions. Yeah, and throw multimorbidity into the equation. Patients juggling multiple chronic illnesses and applying a score designed for just one problem becomes incredibly complex.
How does it account for interactions?
It doesn't. The score doesn't know how that patient's diabetes affects their heart failure risk or how their arthritis meds interact with something else.
So the review really emphasizes this need for much broader validation.
Yeah.
Testing these tools across diverse populations, different real-world settings,
Yeah.
if they're ever going to be truly reliable and widely useful in primary care.
And this leads to what I think is one of the most critical points in the review. The patient-centered gaps. What's missing from the patient's point of view?
Well, a big one is they often just bypass patient preferences entirely.
Right.
What does the patient actually want? What matters most to them? Are they worried about missing work, side effects, cost? Scores tend to be very disease-focused.
Not person-focused.
Exactly. They often don't really factor in quality of life impacts in a meaningful way.
Like that example they use, it's really telling, weighing the maybe small potential benefit of an antibiotic against the very real chance of side effects like nausea.
Yeah. A score might give you a risk percentage, right? But it doesn't capture how much that individual patient dreads feeling sick or how important avoiding that is to their well-being right now.
That calculation is personal.
It is. And that crucial trade-off, that negotiation based on the patient's values, their lived experience, that's exactly where these algorithmic scores often just fall short.
And where clinical judgment has to step back in.
Which brings us right back, doesn't it? Back to the fundamental message running through this review, the absolute primacy of clinical judgment.
Yeah, these scores, they should be aids, tools in the toolbox.
Right, providing a piece of data, maybe a prompt to think about something. But they shouldn't become a burden, or worse, overshadow the clinician's own assessment.
Because that clinical judgment, that's what brings everything together, isn't it? The score data, yes, but also the medical evidence. The patient's other conditions, their history, and their personal values and priorities. It's that holistic view.
That integration. And the source really highlights how vital that judgment is, especially in complex situations like managing chronic conditions, where those simple single-issue scores become even less adequate.
So looking back at our journey through this BJGP review summary, we started with this mind-boggling number, 250,000 scoring systems.
Yeah, incredible.
But we've really wrestled with the source's findings about their real-world impact in primary care, these significant challenges around context, usability in a busy clinic, generalizability to diverse patients, and maybe most importantly, those gaps where the patient's own perspective gets missed.
And the review leaves us, and hopefully leaves you listening, with this really powerful final thought to mull over. It says, algorithms don't heal people, clinicians do.
Algorithms don't heal people, clinicians do.
Yeah.
Thinking about everything we've just talked through, the data, the limits, the human side, what does that line make you think about the future here? It really puts that relationship, that human context, right at the center of care, doesn't it? Something to reflect on.